Good morning. Thanks for having me. I want to thank Elisa and Miranda for organizing this every year. This is fantastic. It's the 10th time. My name is Eric Malek. I'm sorry. I wish that was Eric Malek, but Eric couldn't make it and asked me if I can do it instead of him, and didn't make any slides. So, so sorry about whatever you're going to see. But I decided to change the title because I think it's, as we talk about standard of care, there's a recognition that standards change as we speak. And so it's really an ongoing evolutionary process, and I consider myself part of, part of the evolutionary process there. So that I'm not talking about the evolution of people here, but more perhaps the evolution of the clinicians. There. You know you're getting old when you don't know how to use it. So, yeah, we don't need to talk about what ALD is in this room, but I do want to start off just saying that we are now, when you look at the ALD database that's managed by Stefan Kemp, there is now over 4,000 variants that we can see in the ABCD1 gene. And so it's a rapidly evolving thing. It's almost like you feel like every single DNA piece can be altered and perhaps result in disease. These are over 4,000 pathogenic variants, so where we clearly know that can cause disease. And you know, we know, of course, of the traditional story of what we think about ALD when we talk about men and women or males or females. You know, the traditional presentation of that child with cerebral ALD and AMN and in the adults and adult cerebral ALD in males. And that in women is predominantly the myeloneuropathy that starts later in adulthood. And the more recent data suggests that it might be as high as about 80 to 90% of all women at some point that will have some neurological deficits. But I think this is part of the initial evolutionary process that's changing. And I hope Dr. Eichler will talk a little more about this. Because the question, as we see more and more of these patients, is if there are perhaps more phenotypes. You know, it's like the story of the more you learn, the more questions you have. And so these are there's a question mark there on purpose. I'm not implying that these are additional phenotypes, but these are starting things to see that we don't really know. Is that related even to ALD, or are these just coincidence? Could it be that a person has two different diseases, right? We can have different conditions. We don't have to be affected just by one. We're not privileged to have just one disease. But the new things that we are seeing now, as we are learning more, is, for example, in the adult population that develops cerebral ALD, there's certainly there are a few cases where we feel like there's this emergence of disease progression that then stops, and it seems to come back very rarely. In females, the Boston group has described now for several years this sort of so-called extrapyramidal phenotype, where we see some neck movements that are abnormal, some posturing that's abnormal, changes in speech. Don't know the exact prevalence of that. We've seen some, but we feel like we see it less at Kennedy Krieger than in Boston, perhaps. So there might be some group effects there. And then, there are very rare things that we don't explain right now. For example, there's a handful of boys that have normal MRIs and have other neurologic things, autism, for example. Now, autism is extremely common. It's perhaps one of the most common developmental disorders these days, if not the most common. So it could be a coincidence. You're looking at boys are much more likely to have autism, so maybe it's completely unrelated to ALD. There's also a few kids that we've seen that develop a spasticity and paraplegia without having, again, MRI changes as children. And so it looks a little different than adults. And again, it could be a different disease. We don't at this point know. In adult women, there is certainly extremely rare to see cerebral ALD, although there's a few that we see once every few years, I would say. But when you look at the MRIs, and this has been looked at many years ago, in adults, especially those with obesity, hypertension, diabetes, there's something that's extremely common as we age called small vessel white matter disease. So patchy white matter changes on the MRI. And there's always been a feeling that this may be more prevalent in adult women with ALD. And again, that's something that needs to be explored. So I don't want to go into these. I'm going to just talk about the pediatric standard of care, but I thought this is like a little bit of an editorial on the side. So the story we used to tell about childhood cerebral ALD was, of course, a devastating one, as all of you know. And it was the story of, having initial symptoms that are very subtle, and then there are significant neurological issues, and then rapidly progression to sort of a fatal stage. And these were the MRIs that we used to see, and we unfortunately still see them sometimes, especially when these are kids that are coming, that are not identified through newborn screening, but from other countries, where we see very advanced, and you see the whole brain is kind of white, very advanced disease with a lot of abnormal demyelination in the brain. But that's the classical presentation. And we knew, now for many years we've known that, and this is probably the most comprehensive summary by Dr. Raymond a few years ago, that when we do interventions like hematopoietic bone marrow transplantation or gene therapy, they're highly effective if you do it very early on, when you have tiny MRI lesions, and they're not so effective if you do it late. So early transplantation or early gene therapy is the goal, and that's what we need to do. That's why we ended up having newborn screening, right? And so the aim of newborn screening is essentially to identify boys early on so that we can monitor them closely enough so that then we can intervene during that early stage of the disease rather than the late stage. You haven't learned anything new right now, I'm sorry, but that's just what it is. I know you know all of that. The big question has always been like, how do we monitor them, and how frequent, and how intense? And so the focus here is going to try to answer that as best as we can. So again, this is preceding the extensive newborn screening availability that we have today. The first attempt was to try to reach a consensus agreement based on previously existent data that preceded newborn screening. And so this was a collaborative that really Eric and Bella Turk were heading together with a lot of people in this room and others, including Elisa, trying to do a meta-analysis from the data in the past and trying to see when does cerebral ALD really start in boys. And you can see here this distribution that really implies that the vast majority of patients present between 3 years and 12 years. And again, wasn't much new stuff. We knew that based on clinical experience, but it was important to quantitate it so that you can come up with an estimate as to how early you should start doing MRIs. And there were some individuals that seemed to start as early as perhaps 2.5-ish or so, but it's extremely rare. There are some reports of kids at 1 year of age, and even one, as far as I know, that is less than 1 year. But there is a serious question whether that was actually cerebral ALD, and I think I would argue that was probably a misdiagnosis of something else being considered cerebral ALD. There are some circumstances when you, for example, could have a severe adrenal crisis that results in hypoglycemia and hypoxia to the brain that could trigger an inflammatory process, but that wouldn't be called sort of classical cerebral ALD. And so based on that, and the fact that we knew for many years that gadolinium enhancement in boys is a strong predictor of disease progression, and furthermore, the Minnesota group had shown that not only the presence of gadolinium enhancement, but even the intensity of the gadolinium signal, which is called the GIS, is a good predictor of how somebody will respond to therapy. It seemed that it was important to do gadolinium-enhanced MRIs in these boys so that we can identify early lesions and we can identify who's going to progress. So based on that, there was the first consensus paper that's now 6 years old almost, at least 5, depending on what publication date you look at, that essentially recommended to start screening, and a lot of people again in this room were there. We said at that time, well, start MRIs between 12 and 18 months, and then do the second MRI a year later, and then between 3 and 12, do it every 6 months with gadolinium. That's what was written in that paper. And so just shortly after that, there was the same group meeting up with some of our international colleagues, especially led by our friends in the Netherlands. And that resulted in another paper that included, again, every person here in this room, that came out a year later, talking about international recommendations as to how to monitor. And there, the consensus took a little more of a I would say, international approach to this. And so there it was decided that we start screening to make it kind of a little simpler at 2 years of age. And between 2 years and 12 years, we scan every boy every 6 months. The issue of gadolinium enhancement was not fully like yes or no in that paper. It was like, in general, let's try to avoid, unless you don't have the option of having somebody getting the scan again easily. And so this is, again, all based on the data that we have from the past when we saw the disease more advanced. The question is, what is the new phase of ALD? And I have permission from this dude's dad. This is Will, Cure for Will to Cure ALD Foundation's son, who is a boy identified through newborn screening, very cute toddler. That's the new phase of cerebral ALD that we're seeing. These are the boys that are really catching them extremely early in the disease stage. And so we are really starting to understand this disease better. It's not that the disease is necessarily changing, it's that our understanding of the disease is changing as we're studying it more thoroughly. And so here now, we're dealing with these tiny lesions that Eric published together with Florian Eichler several years ago, where you start seeing these, you probably can't even see it from there, but if you look at the baseline, maybe a little something at 6 months, there's a little dot in the center of that MRI, I'm sorry, can't pinpoint to it. And that little dot keeps growing and then eventually gets bigger. And on the bottom, you see it in the frontal side, where there's that little dot that again spreads. And you can see that the rate of change is relatively slow in these initial stages. Although from a volumetric perspective, the volume growth is actually really fast. But because it's so tiny, when you go from 1 cubic millimeter to 2 cubic millimeter, it just barely looks like a change to the eye, even though it doubled in size. And actually, if it grows by 1 and 1 in each direction, remember, it's a volumetric, so it's not just doubling in size. So as we are learning this new phase of the disease with these tiny lesions, and here's some other examples from that same publication, we don't need to go into that. It really requires us to rethink a little bit as to how we approach this. And so there is sort of 3 questions that Eric has been trying to answer now for several years. And we have some answers to it, but it's still always refining. The first is, at what age do asymptomatic childhood cerebral ALD lesions first appear? The same question we had. How early should we really start? The second question is, what is the time from the lesion, from the very first evidence that there is a tiny little dot, to the time that it starts actually showing gadolinium enhancement, which would be for us an indication to go ahead and do the therapy, because we typically don't want to do gene therapy or bone marrow transplantation without the presence of gadolinium enhancement, which implies that the blood-brain barrier is breaking down, and it allows actually these stem cells to get into the brain. And then the third question is, from the time you see that tiny enhancement, how long does it take to actually develop symptoms? Because we know that initially these things are silent. And so these are the questions he's been trying to answer. In terms of the age distribution, he has looked at additional data sets, and there is a multi-center collaborative going on right now. I think Dr. Van Haren is talking tomorrow about his study that is going to give you some more bigger numbers. From the prior publications, again, it really looks like it's extremely rare to start presenting before 2 years of age. The second issue is, from the time of that initial lesion to the first time when you get gadolinium enhancement, it appears to be about 6 months. Of course, there is a selection bias here because we're doing imaging every 6 months typically. So if it were to happen earlier, we won't necessarily catch it. So this is an estimate, but it does seem like it's a decent estimate. And then lastly, it seems like currently, at least in the United States, from the time somebody gets that lesion enhancement to the time until they have actually gotten their first dose of gene therapy or bone marrow transplant is typically 4 months. Now, that is the average, and it has to do with a lot of factors, of course, like HLA typing, finding a donor, resources, insurance coverage, which is where they live, social demographics, and coexisting conditions, and so on. So taking all this into account, the other question is the tough one, and that is, how long does it take from that tiny lesion on the left side to develop a late lesion that is perhaps too late for a good transplant. And that's difficult to estimate, again, because we don't want to sit there and wait and watch people. So this has to go back to the old existing data. And so one of the things that Eric sees is that to change your so-called less score, which I think you might hear a little more about from Dr. Riemann, from 2 to, say, 9.5. 2 is the early disease, 9.5 is the advanced disease. Advanced, but still amenable, perhaps, to bone marrow transplant, but not so good outcome. On average, that takes about 3 years, right? So that means that on average, the less score changes about 2.4 points. The problem is that the less score is not a linear score, because the way it is assigned based on its anatomic locations, it can rapidly go up, and then you can actually have a lot of lesion growth without the score really changing. So this is not a very good estimate probably in the long term, but it gives us an idea that we do have some time, at least from those tiny little lesions, to intervene. We don't have to like immediately jump on it, although we don't want to wait too long neither. So right now, based on that, this is sort of what the practice is in the newborns clinic at Kennedy Krieger, and I suspect it's the same at most other locations. We are starting imaged kids basically at 1.5 years at the first time, just before their second birthday. By doing so, we can then just continue every 6 months. So starting at 2 years, this is like the standard international recommendations. And we go up till 12, and then we do it annually, and we'll talk about that annually in a bit. In terms of gadolinium enhancement, there's something to say from a scientific perspective, and then there's something to say from a practical perspective. From a scientific perspective, the likelihood of gadolinium enhancement, of course, in the initial, in those initial few years of life is low, because the probability of disease lesions is low. Having said that, and we would like to avoid gadolinium contrast, because it does have an FDA label of side effects and so on, although that's probably a little bit overblown. But sometimes you can't avoid it, and that's the practicality of this. So it really depends on the circumstances. If I have an MRI being done, for example, at our hospital, and it's from a resourced patient, and it's especially someone who doesn't need sedation, for sure, why not? Let's just do it without the GAD, and if there is a tiny lesion, then we bring him back. There's really no harm to anyone. The reality is, insurance companies might be like, no, we're not going to pay for another MRI. He just had one last week. The other reality is that they might be living in rural West Virginia, 5 or 6 hours away from a place that can provide the imaging or can provide an appropriate reading of the imaging. And then there are other factors, social factors. Some people are very, very anxious, and they can't live with the idea of having to wait, let's say, another 4 weeks to see if their son's MRI is enhancing or not. And I think it's really depending on all these circumstances, and we take those into account when we make these decisions. So it's hard to be black and white and say, let's do this or let's not do this. It really is the general idea is to try to avoid it if you don't need it, but we do it if it is needed. And we've been doing a pretty good job in this last year or two with our team to be able to have that conversation with families and avoid it if we can. In terms of what MRI sequences should be done, I'm going to show you in a second a slide. There's also a question whether we should do something called neurofilament light chain plasma levels every 6 months when they come in. It seems to go up when cerebral ALD happens, but its predictive values is still unclear. It's still really a research question, although it's a cheap test, and definitely a lot of centers have started doing it. Not exactly sure what we would do if we see an elevated neurofilament light chain if the MRI is still normal. So it's really more an addition rather than a decider at this point. Just mentioning in terms of what MRI sequences to be done, again, the consensus approach was taken. So, when we say consensus, it sounds like we're being smart, but what it really means is like a bunch of people not knowing what to do, and they just get together. I'm joking, but there's a strategic approaches to this. Has to do a survey where you ask a bunch of questions. It's called the Adelphi approach, and then you get responses, and then based on those responses, you fine-tune the survey. You go back again and ask again, and you really try to see what percentage of the majority is saying something, and if there's sort of any dissent, you outline their reasons as well. And so this is a paper that just came out a few months ago. where it was sort of a decision-making as to what protocols should be used for screening, and then also once we have a lesion, what protocols should be used to monitor them. And we came with a core sequence that we are hoping every center can really do. And essentially these sequences that we're listing there can be done at pretty much any MRI facility in the Western Hemisphere at the very least. The optional sequences are more things that we would like to do, but they're research, really, because we don't really know what clinical implications they will have. But we are hoping that this approach will try to align us as multiple centers to sort of try to collect the data prospectively, because this will be very helpful. Just a final note on, okay, what about the plus 12? So once you reach your 12th year, the risk of cerebral ALD in childhood certainly goes down, but it doesn't go down to 0. And what is the actual incidence of adult cerebral ALD? Still, I think I gave a talk here 2 years ago, and unfortunately, it's just the same slide. So still under investigation. I do have good news that there is multiple centers really interested in this question. There is a study that is done right now in Netherlands that we are, and multiple centers are part of, and there is a study done in Germany by Caroline Bergner and Wolfgang Köhler's group, trying to really get to the bottom of this and collaborating with all the other centers and people who are here in this room. But the issue is that it's more than just one type of brain lesion in the adult population, and there are different types of brain lesions. And at the very least, there seems to be 4 patterns. This was actually published by Florian Eichler many years ago. Not too many years ago, because he's not that old, but yeah. So there is this sort of corticospinal tract pathway that seems to be a bad indicator for bone marrow transplantation, especially if there's gadolinium enhancement there. There's the periventricular type, which seems to be actually present in many people and does not seem to necessarily always progress, especially if it's not enhancing. There is the cerebellar phenotype, where there is primarily lesions in the cerebellum, in the hindbrain, and typically every patient I've seen with that disease has had progression, pretty rapid progression. It's not been a good outcome. And then there are those that seem to have traumas and strokes, so focal lesions to the brain, and even sometimes in the setting of a surgery, that then triggers demyelination from that area where there was a trauma or there was injury to the brain. Those sometimes progress rapidly and then stop. And again, we don't have any markers right now to be able to guess who's going to stop. And that's really still under question. Overall, the minimum prevalence of this is 20%. The more realistic number is probably around 50%, lifelong risk. And that's why we think we should do yearly MRIs, because if we catch this early, we still can really consider bone marrow transplantation at the very least today. And the outcome is not that great as like in the boys, but the earlier you catch it, and depending on the type of MRIs, you will have better data. There's also clinical trials. There's at least one right now called the Calyx trial that's still recruiting. That is a placebo-controlled trial of a drug called leriglitazone. And just as a disclosure, we are part of the trial. That is an opportunity for patients with adult cerebral ALD. So I just want to end up here by thanking our team at the Motion Center. It's a pretty big team, and I'm the non-designated speaker, and our collaborators. Thank you. Can you see now? Oh. Do you have a microphone?
Thank you. That presentation was great. I wanted to ask a question about the data on the kind of lesion evolution and velocity. I think you've shown pretty convincingly that, you know, in most cases, or in the average case, the lesion is moving pretty small, and there's kind of this window to watch and wait. But I also have seen, you know, a few patients who've had really rapid lesion growth from the start. So serial MRIs showing no lesion, and then 6 months later, a pretty sizable lesion. And they may be outliers, but they are, it does occur. Yeah. And how do we go from like good enough, every 6 months to like, we're going to capture this for everyone? Do you think there's a role for some of these other modalities in those cases?
Definitely correct that there are, when you look at the individual data points, there are some with the much more rapid progression. And there are also the ones that oftentimes is so fast that by the time you get into transplant or gene therapy, it's just too late. And you see that actually in those data sets, right? That even in the New England Journal, there were a couple of kids that were like just way too fast there. I don't think we have any way to predict that right now. I think that's really an ongoing effort. And maybe NFL is helpful there, because that's a question. If the NFL were sky high in a kid who has still a normal MRI, what would you do? Would you wait 6 months? I don't know the answer to that. Maybe somebody else in this room can answer that question. But that is a tricky one.
You talked about GAD enhancement showing that there's further breakdown and it's affecting the blood-brain barrier, but I have a question about the risk of transplanting prior to that. If you have a lesion that's been present, say from day one, 18 months, and then you get to your short interval, the 6 months, it's continuing to grow. You're doing shorter interval at that point, maybe 3-4 months, continuing to grow. It's not stopping. What is the risk of transplanting prior to GAD enhancement?
Yeah. I think the bigger question is what is the efficacy, and I think that's the concern. And I'm not a transplanter, but the idea here is that you need to have that disruption of the blood-brain barrier for the hematopoietic stem cells to actually do what they're supposed to do and get into the CNS. Now, it's not as simplistic as that, because we know that these hematopoietic stem cells may also differentiate into the cells that are outlining the vessels themselves. So nobody wants to transplant people who don't have GAD enhancement. Let's say this way: has it been done? Are there people who are progressing without gadolinium enhancement? Rarely we see that, and should they be transplanted? It has been done. I'm not sure if I've seen good outcomes on those. That will be more the Minnesota group being able to answer that question. I don't know, Jerry, have you seen people who don't enhance and got transplanted and did well?
Yes.
Okay, good. That was the answer. Yeah. Right. But was the MRI just lagging behind anyway?
So what would be the follow-up then after that, your recommendation for, say they did transplant, like we did, we transplanted less than a year ago. We did not have GAD enhancement. However, the lesion was evolving, behavior was changing, clearly symptomatic. And my question would be then, if the concern is whether or not it's efficacious, then would you do shorter interval MRI follow-up after?
Well, I think the issue is this: if you see the MRI lesion, you're no longer screening, right? By the time you have an MRI lesion, you're starting to monitor the disease, and we don't wait 6 months. So just to be clear, the 6 months every time is if you have a normal MRI. Once you have the abnormal MRI, depending on the lesion, again, if it's enhancing, you're going to go ahead. If it's not enhancing yet and it's a tiny little dot, we have been starting to work on preparing for the transplant. Whether it's HLA typing, whether it's gene therapy, whatever path it's going to be taken. We usually do the referral to the bone marrow transplant team at the time. And we don't wait 6 months. So we have been imaging them after 3 months. If the lesion changes within those 2 months, that's a very good argument. Honestly, I've not seen a lesion changing in 3 months without enhancement. I've not seen that yet. I don't know, these tiny ones, so maybe somebody else has. But my guess is that there is already blood-brain barrier disruption, but it's maybe so small that you can't even see it on the imaging. I don't know. Aren't you going to talk about this stuff? Yeah, and off the hook. I'm off the hook. Okay. I think he wants me to sit down. So.
I have a.
Yeah, sorry. Was there a question?
I have a question. I think you recommended the first MRI done at age 1.5. So from public health, the perspective of newborn screening, you ask parents waiting the period of time. I'm a little bit concerned is because during the first 1.5 year, the boys appears looks okay, everything. Are we in the position to lose the family?
So there is a difference between follow-up in the clinic and imaging. Yes, the imaging will wait because I can tell you, anytime we do imaging in less than a year and a half, it causes more confusion than not. But because the brain is still immature myelinating, but we do really emphasize follow-up in the clinic. So it's not like we don't see them until a year and a half. As soon as they have a diagnosis, we schedule a follow-up appointment with the neurologist, we schedule an appointment with the endocrinologist. They see them typically from an endocrine side every 3 to 4 months. Neurology, depending on the level of involvement and engagement of the patients, might be also every 3-4 months, sometimes every 6 months. And then we go to that. So we don't let them go out for a year and a half because yes, that will be a big challenge. And that has been the challenge I know in New York State, when Eric was here, he actually had that problem with some of the patients not following up, especially on the more undersourced individuals, yeah.
Thank you. My key thing is why you don't choose to do before, and you just answered, because the reliability.
There's a couple questions in the chat, so I don't know if I should go ahead. I don't know where Miranda is. No, I can't find it. One is, why is MRI recommended once a year in children over the age of 12? Is there scientific evidence suggesting that the progression of brain demyelination becomes slower? This is from a mom of a 13-year-old.
Yes, so one of the figures that we showed was when you see that peak of the disease, that's around 6 years or so, and then it goes down. And after 12 years, it's like pretty flat. You still can develop cerebral ALD, but the likelihood of it is much less than when you're younger. And there is perhaps even a window of sort of a honeymoon between that and the adult stages. But yes, you can develop cerebral ALD still as a teenager. And yes, the experience is that the disease progression seems to be a little slower from an imaging perspective in those teenagers. And so that's why we think every year is sufficient.
Okay. And there's another question that says, great talk, thank you. From a neuroradiology standpoint, is there a clear differentiation between a lesion and immature myelination? Especially in our,
I think it depends on the radiologist skills. So that's a question for Dr. Raymond. Yeah.
Okay. I think that's it.
Thank you.